All right, good morning, everyone. I'm Rick Lang, the Navy PGY-4 here, and today we'll be talking about neurogenic claudication and lateral recess stenosis, and we're going to expand this a little bit to foraminal stenosis after talking to Dr. Bruffy about it. Just definition-wise, lumbar spinal stenosis is a reduction of the volume of the central canal, the lateral recess, and/or the neural foramina that decreases the space available for the thecal sac and/or the exiting nerve roots. So, given the fact that it can affect the thecal sac or the nerve roots, there's a pretty variable presentation. Mild disease can present pretty asymptomatic. There can be low back pain, radicular pain, neurogenic claudication, or any combination of the above symptoms. Kind of the outline for the lecture to talk about the topic. We'll talk briefly about epidemiology and anatomy. We'll tie that in throughout the presentation and the talk today. We'll hit clinical presentation indications as well as treatment options. As far as prevalence, lumbar spinal stenosis, most common reason for spine surgery in patients over 65 years old. About 9% of the elderly population suffer from symptomatic lumbar stenosis, and over 500,000 laminectomy procedures are performed for lumbar stenosis annually. The average age is around 64 years old, and 84% Caucasian men are more affected than women generally. So this is predominantly a disease of elderly Caucasian men as a predominant kind of patient population. The financial impact and lost work hours, about 1.4 billion each year in the U.S., so pretty significant disease burden. Risk factors being age, obesity, tobacco use, and congenital stenosis. It's kind of a degradation cascade. It starts with degenerative disc or disease, and then anterior column, whether it be collapse or just reduction in height, that leads to an abnormal force transfer to the posterior column, ligamentum flavum buckling, facet hypertrophy, and osteophytes with facet overload, and then plus or minus synovial facet cysts that can also contribute to pathology. There are other contributing factors and variations in the condition to include degenerative spondylolisthesis, which we'll talk about a couple times today, but not the focus of our lecture, as there's another topic in academics later in the year devoted to degenerative spondylolisthesis. Achondroplasia and other congenital anomalies or facet cysts can contribute. As far as kind of the anatomical regions we'll discuss, there's obviously the central canal for central stenosis, there's lateral recess, and then there's foraminal stenosis. We'll not be talking about anything far lateral herniations. That's less about stenosis and more about a disc herniation. But those three regions will be our kind of region for discussion today. So central, lateral recess, and our foraminal stenosis. As far as the workup for these conditions, so you're going to do a history and physical exam. We'll talk specifically about how these present in the history and physical exam briefly when we talk about each condition. X-rays, you may want to obtain flexion extension X-rays versus a CT scan, really to look for mobility, because if it puts this, if found to be contributing, or degenerative spondylolisthesis is found to be contributing, then that can change your treatment algorithm dramatically, resulting in a requirement for a fusion. Obviously MRI, and then injections, transforaminal or interlaminar injections, those can be diagnostic versus therapeutic. And we'll talk a little bit about the results of those when we talk about treatment. So for central stenosis, this is our first big category. The anatomy of it, right, is bounded anteriorly by the disc space of the vertebral body, the posteriorly by the ligamentum flavum, and then the facet joints posterior laterally. The etiology of them, you generally can have broad-based disc bulge and then ligamentum flavum hypertrophy and facet overgrowth posterior laterally. 90% of these conditions, or 90% of the patients, will present with pathology at L4, L5, 5 to 10% at L3, L4, or L5S1. So predominantly L4, L5 here with degenerative condition. They will generally present with neurogenic claudication. If they have a radiculopathy, which we'll talk about shortly, generally that means they have concomitant lateral recess stenosis or foraminal stenosis. But if you have just central stenosis, the common association is neurogenic claudication. And there is an association between central stenosis, lumbar spinal stenosis, and degenerative spondylolisthesis, as well as degenerative scoliosis. So you want to take a look for both of those conditions, and that's drives our, desire to have FlexX films to look for stability, or just compare your standing x-rays to your supine MRI or CT scan. The general etiology for it is decreased perfusion to your nerve roots. There's different theories, whether it be via a decreased arterial or a kind of venous overload. Either way, you get an oxygen demand mismatch presenting in symptoms with the patient's lumbar spine in extension or standing position. Generally, it will present as low back pain radiating to the bilateral buttocks and bilateral posterior thighs. It is not normally found to be unilateral. So the key here is bilateral symptoms, buttocks, posterior thighs, exacerbated by standing, walking, or lumbar extension, and relief when they sit down, put the lumbar spine into flexion, ride an exercise bike, etc. Usually they have a normal neuro exam. They may have some wide base gait or blunted reflexes. However, generally, unless they have a radiculopathy, you won't find focal weakness or a focal radiculopathy. You do want to make sure that in your exam that they do have normal distal pulses, because if there is concern for vascular claudication, slightly different presentation, but then you need to run full vascular studies to make sure that they have this is not confounded by or it's not vascular claudication rather than neurogenic claudication. There's a variety of classification schemes. We won't go into these because none of them have really been shown to predict treatment or outcomes. However, they do help with evaluating your imaging to make sure that you're looking at the right pathology. On the right, Leonal showed that it's generally loss of the anterior CSF or CSF space anteriorly, and then you get decrease in space between the nerve roots, and then leading to loss of all space between the nerve roots. Laurie and all showed, you can use the mild, moderate, and severe, less than 1/3 decrease in the canal, 1/3 to 2/3, or greater than 2/3. But there's a variety of different ways to kind of classify lumbar spinal stenosis as far as mild, moderate, and severe. But none of these have really been shown specifically to predict the patient's presenting complaints or the outcomes. If we shift a little bit laterally to lateral recess stenosis, kind of some comparisons in contrast, the borders here are your vertebral body anteriorly, and then laterally your border is the medial wall of the pedicle, and then posteriorly your ligament of flavum as well as your SAP, which is kind of commonly implicated in the pathology. The etiology most commonly is shown on the right picture here by Siricanol in 1980 is facet joint arthropathy with SAP hypertrophy. It can be due to a herniated disc as well, and we'll show some of the difference in symptoms with that. But you get osteophytes, you can have a synovial facet cyst, and you also may have spondylolisthesis as a contributing factor. These clinically present with L5 and S1 nerve root symptoms. So this is more radicular in nature rather than neurogenic claudication. A lot of times they are unilateral if it is a unilateral facet hypertrophy or a herniated disc, but it could be that they just have facet hypertrophy bilaterally, and you can get bilateral symptoms. The symptoms do vary based upon pathology, and I'll show a study talking about that. Same kind of deal with classifications. There's really poor correlation with patient symptoms. It doesn't really guide treatment, but just a way to look at lateral recess stenosis. Stewart and all looked in 2011. The lateral recess height less than 2 millimeters, the narrowest distance. And then if you look at the superior aspect of the pedicle, you can look at the depth of greater than 3 millimeters, or you want greater than 3 millimeters there, or the difference between the floor and the ceiling. An angle of less than 30 degrees would indicate lateral recess stenosis. So there's just some measurements to look for on MRI in the case you're looking at that as a potential contributor. This study out of CORN in 2002 looked at the difference in symptom induction by lumbar flexion extension and age, and they found that if lateral recess stenosis was as a result of facet hypertrophy, only 10 to 30% of patients had difference in symptoms with flexion and extension. However, if it was due to disc herniation, you're going to find 50 to 60%. Many more patients are going to present with symptoms of symptomatology with lumbar flexion and extension. So just a little bit of difference in the history taking that you may be able to discern. Obviously, we would find it on imaging as well, but there is a slight variance in presentation based upon the underlying pathology. And there's also an age difference as well. They found that age, 40 to 50, 40 to 60-ish is more consistent with lumbar disc herniation, or that's when most of those patients would present. Whereas the facet hypertrophy, a lot of those are age 60 to 79 or over 70 years old. So much older patient, unrelieved by flexion extension. You're thinking maybe this is more facet hypertrophy. A younger patient and differences with flexion extension, radicular pain, you're thinking more maybe a disc herniation. As far as treatment, non-operative and operative. For non-operative physical therapy, PT, NSAIDs, activity modification, TENS, and bracing. Not a ton of evidence showing that it's going to provide great relief, but you can give it a trial depending upon the neurologic status. Epidural steroid injections have been shown to provide some short-term relief, but no change in the long-term outcomes. Results are pretty variable at 10 years with non-operative treatment. They're showing about a third of the patients improve, a third remain unchanged, and a third clinically worsen. So kind of a mixed bag there. Indications for surgical intervention, failed non-operative management or imaging confirmed moderate to severe stenosis and worsening or functionally limiting neurologic symptoms. We'll talk later or in a different lecture about the mobile spondylolisthesis, but in general, those are the kind of main surgical indications. As we dive into kind of treatment for our central and lateral recess, there's three main camps to kind of talk about. And looking at the literature, I try to break it down into these categories and highlight the pertinent, salient points from each of these treatment algorithms. So on the left, laminotomy, we're basically leaving the posterior ligamentous complex intact and maintaining our tension band. Because of that, the theory and the literature shows that you have, improved posterior stability. As long as you preserve around 50% of the pars and the facets, you can generally perform bilateral laminotomies at all levels of the lumbar spine with no significant instability risk, either unilateral or bilateral or multi-level. So that's improved from laminectomy, which we'll talk about. The laminotomy compared to laminectomy has been shown to have reduced post-op pain and a lower risk of dural tear, somewhere on the order of 3 to 5% with an experienced surgeon. And the considerations for it, though, as you get higher in the lumbar spine, so L1 to L3, due to the narrowing distance between the pedicles there in medial lateral, you may require a near full facetectomy to relieve symptoms or to get appropriate decompression of your lateral recess. And you also may be able to, due to that same distance in certain patients, be able to obtain a bilateral decompression through the same side. That those two kind of criteria are not as effective at lower lumbar levels. So that's kind of a caveat for your upper lumbar levels, which we know from our prior slides are generally less affected than our lower lumbar. For laminectomy, obviously, if we're going to remove our posterior ligamentous complex in our spinous processes, that is found with multiple level laminectomies. You can get up to 3 to 4% risk of post-laminectomy instability. That will generally present as a spondylolisthesis, or most patients that have that instability present as spondylolisthesis. There can be some higher postoperative pain and a higher risk of dural tear, up to 10% with laminectomy. And there's also a risk of epidural scarring. Because of that, certain centers are doing MIS tubular. If we look at MIS tubular approaches, they're shown generally to have a little bit longer OR time. However, they have less blood loss and shorter postoperative recovery time, mainly because, or the theory is that there's less disruption of your paraspinal musculature. Outcome-wise, as long as you address the underlying pathology, then the outcomes have been shown to be similar. And with regards to the relief of leg type symptoms or lower extremity symptoms, the kind of counterpoint to that is that you need to be able to address the pathology. And there's some concern from surgeons that you don't really get as good of a visualization as doing a full laminotomy with a microscope, and therefore you may not be able to address all the underlying pathology. A technique article, or just looking at laminectomy, from 1980, and there's a common theme here when they talk about laminectomy for central and lateral recess stenosis. On the right, it's just showing that basically the rendition, you need to get all the way out to the medial wall of the pedicle for your decompression, and that will help you to ensure that you've got an appropriate lateral recess decompression. Same kind of thing if we do a laminotomy. This is a picture of one of Dr. Bruffy's cases last week. The dura here is shown in the center, kind of medial on the midline here, and then moving out laterally. Nice lateral recess decompression.
I don't see any clear fluid. Where's the clear fluid?
Yeah, this is a CSF-free case here. No clear fluid, no red fluid either. So it looks pretty good. And then you want a nice decompression out to the medial pedicle wall. Kind of keys to success for decompression there: visualization and removal of the offending pathology, whether that be the SAP, a herniated disc, or a facet cyst. So the key is to visualize it and remove that pathology. Making sure you get out all the way to the medial pedicle wall, and then remembering that upper lumbar levels may require increasing levels of facetectomy, given the facet narrowing and the angular change, and that may result in increased levels of instability depending upon the number of levels you're doing. There are some other treatment options. Interspinous spacers are out there. The goal there being a block extension, and you don't have to do a decompression, but revision rates are almost 40% for those. And then decompression and fusion more for full facetectomy and mobile spondylolisthesis per the SLIP trial, which is kind of a separate lecture, so we're not going to get into that today. It would not be a lumbar spinal stenosis lecture if we didn't talk about the SPORT trial in 2008. So just as a reminder, they were looking at lumbar spinal stenosis without spondylolisthesis. The trial that looked at spondylolisthesis was a SLIP trial a few years later. And in that SPORT trial, that a high crossover rate, that's one of the common limiting factors that people cite, but they had an observed and a randomized control groups of about 300 patients apiece. They found that surgery compared to no surgery, they had increased or improved pain and functional outcomes with a decompression compared to non-operative management, and that was sustained at 2 and 4 years. And then they've actually done that out to 8 years and shown in the observed cohort that the benefit of surgery has been maintained in that group. Was maintained out to 8 years, with improvement in leg pain more than back pain demonstrated in the surgical contingent. In 2019, the CSORN study out of Canada, they went and looked at back pain, how effective surgery is in relieving patients' back pain. So they had 1,200 patients, multi-center, lumbar spinal stenosis without instability, so similar patient cadre to the SPORT trial. All patients had back pain and neurogenic claudication, and they looked at 2-year outcomes and found that not only is surgery effective in relieving patients' leg symptoms, almost 75% had a significant improvement in their back pain as well as their leg pain, and almost 50% of patients had no or minimal back pain out at a year, compared to only 7% having back pain at their initial index presentation. So just showing some results that surgery will help. For counseling, you may have some gain with improving patients' back pain, although predominantly it's leg symptoms we talk about with a lumbar spinal stenosis. The kind of last section here is foraminal stenosis. So a little bit of an add-on to the lecture here, but if we take the compression out a little bit more laterally, then this area is defined by the vertebral body anteriorly, the pedicles superior and inferiorly in that interpedicular zone. Here there's a ligamentum flavum or a portion of ligamentum flavum, as well as the facet posteriorly, and then upper lumbar. There's more osseous coverage of your foramen than your lower lumbar region, and that kind of ties in with the reason for we may need to have more of a facetectomy as we go more superior in the foramen. The thing to remember is that the foramen is about 2 centimeters, 20 to 23 millimeters high or in height, and we'll show what some of the literature shows for how to detect compression. Generally, this is a disc degeneration, osteophytes, spondylolisthesis, or scoliosis. The big thing being determining whether there's foraminal collapse rather than just a disc herniation. And these can be dynamic or static. So there are patient populations that have symptoms. However, on imaging, it does not look like they have foraminal compression. It's been found that extension itself or lumbar extension will drive foraminal narrowing by about 15%. So if it's close and they're getting symptoms in extension, it's likely to have a dynamic foraminal stenosis. Just something to look out for, as it may not be picked up on imaging. These generally present with nerve root compression, L5 nerve root 75% and L4 15%. And then because the dorsal root ganglion can live right here, especially at your lower lumbar levels, there can be significant radicular pain associated with the foraminal stenosis. On imaging, X-ray and CT scan, we're looking, here's large osteophyte and foraminal collapse here. You're looking for a foraminal height greater than 15 millimeters. If it's less than 15 millimeters, you're thinking it's likely foraminal stenosis. Or if you see a posterior disc height of less than 4 millimeters, specifically in the concavity of any kind of degenerative curve. On the T1 MRI shown here, loss of perineural fat is another way to make sure you're looking at the neural foramen. The key here is, looking at these two numbers, that'll kind of set the stage for why interbody will help to improve the foraminal height, because we can both increase foraminal height and our posterior disc height. Treatment options are indirect or direct decompression. We'll get into this in the next couple slides and show some of the data, but for indirect decompression, generally, in interbody, variety of different flavors plus a fusion. For direct decompression, as shown here by Epstein et al., and that's not 2022. That's a typo. I'll fix that. But foraminotomy, you can do a medial, depending upon where the compression is. Obviously medial facetectomy through a midline approach. You could do a lateral foraminotomy through a Wiltse approach. If it's more lateral compression, a full facetectomy, potentially requiring a fusion there, or you can do combined midline and lateral, and there's also MIS and tubular options. Some literature showing the benefits of indirect decompression because of that loss of foraminal height and the posterior disc height. This study looked at ALIF and compared it to some of the outcomes of TLIF, and they found that an ALIF will provide about up to 25% increase in the foraminal height, provide 67% increase in foraminal area, 40% in width, and also a concomitant 43% in the increase in the central area, in addition to the foraminal space, and an average improvement in lordosis of around 11 degrees, and that number depends on the study, but you're getting about 10 to 15 degrees of lordotic correction as well as your decompression of your foramen. They looked at comparing that to TLIF and found that in TLIF, they actually found a decrease in almost 0.5% in foraminal height and only about a 1.7 degree lordotic correction. So showing the power of ALIF or bilateral compared to TLIF for your foraminal decompression. Now, last paper looking at endoscopic foraminotomy on the left. Obviously an L5 foraminal stenosis, and they did a endoscopic foraminotomy at L5. They actually found that, same kind of thing. If you can identify the pathology and you can address it, 15 to 20% increase in foraminal height and a 40 to 50% increase in foraminal area. So maybe not quite as much as an ALIF as we found from the numbers on this slide, but you can get a reasonable correction. One of their conclusions is that indirect decompression is more effective for the foraminal stenosis due to disc height loss, but the direct decompression is effective for more long-standing spondylosis due to overgrown facet. So that'll kind of drive into our algorithm for how to treat these. If you have a patient that has a foraminal height loss, more than a central, canal area loss, so something like a disc degeneration or posterior height loss, then indirect decompression by interbody will generally provide you the best relief of symptoms. It'll improve your ligamentum buckling, or your ligamental flavum buckling, your annular tension, and then improve your interpedicular distance there, restoring your foraminal canal or your neuroforamen. Direct decompression does not necessarily do that. However, it is a good option when the indirect decompression is less likely to address the pathology. So when would that be? That is things like fixed structural compressions without as much height loss. So severe osseous or ligamentum flavum buckling that from a facet hypertrophy or spondylosis that is driving significant compression with maintained disc height, for example, or reasonable disc height, where just bumping up a disc height isn't going to necessarily address the pathology. Those are times when you would probably err towards more of a direct decompression for a foraminal stenosis. and it also is more effective generally if the patient's symptoms are more central stenosis in origin, more neurogenic claudication than actual foraminal stenosis. So if that's their predominant presenting complaint, then central or direct decompression may be a better option for them. So that's the slides. Thanks to Dr. Bruffy for his guidance on this, indirectly for Dr. Eastlack through showing me over the last month that not all decompressions are created equal. One of my main takeaways there, and for helping me to see that there are a variety of different ways to attack the problem through decompression, depending upon the offending pathology.
Jamie, I taught him all about self-irrigation through clear fluid, so that you wouldn't have to.
Oh, sorry.
And I just am so afraid of it that I do everything I can to avoid it. So other than irrigation at the end of the case, man, that's the clear fluid I want to see. The stuff I squirted in there. So, no, very nicely done, Rick. Good comprehensive talk. Nice discussion.
Thanks.
Nice work, Rick.
The question on Thursday, I thought that there was a study that one of the fellows did on indirect decompression, that the sign of not improving the symptoms when they're supine versus standing. Was that ever published or carried out? I don't know who he was, this person who was doing the study.
Outside of our institution, Bears?
Indirect decompression. That was there was some data was collected that patients who had improvement by laying down versus standing, and
that was us.
Predictive factor for improvement. Was that ever published? Or
That was Omri. I think that I took that. Right, we got that published.
Oh, okay. Yeah, that would. I just wasn't sure.
Yeah,
We're trying to expand it, and we haven't published the last one, or the latest one, I should say.
I think we used like question 7 of the ODI as our predictor of symptoms at rest versus when they're mobile, and then correlated that to the indirect decompression. And then we took it to the next level. We started asking patients more direct questions, and then I think that's the one that we're now working on with what you call its data, right? Dan's data. It's still a work in progress. the next phase. Hey, great job, Rick. That was awesome. Appreciate you taking the time, and that was very succinct and applicable, and a very, very good logical talk. So appreciate it, man. Thanks for your time with us too. You've been a great part of the team, and everyone's loved you. So thanks again for working so hard for us.